just.
Now, were these in here?
Yeah.
Okay,
We
so
left them in there
On
last time,
the
right?
lateral aspect,
yeah, we have to
we
count
can
them.
see the exertion of one of the
These are
five
suction
members
tips.
force.
And we already have, actually, we don't
Often
have
surgeons
suction
will
tips.
just
Okay,
insert a
we have
blade
that.
with
So
a
go
pencil
ahead and we
just to
count
keep the
these
parachute prior to
laparoscopic
this.
instruments as just 1, 2, 3, 4.
So 1, 2,
When you
3,
first
4,
insert the laparoscope,
5,
you often be encountered by this initial view of the right upper
7,
quadrant.
8, 9, 10.
Here, you can see the gallbladder
Okay, how
sitting
about
in the
suction
gallbladder
tips?
bed.
Those you
We
got
have
the
some
well.
fat
Yeah.
adhered to the gallbladder
Uh-huh.
surface.
Okay,
and you can
15
see the
total.
liver behind.
And the cord.
Next, we'll talk about
What do you
gallbladder
say, 1 quart?
retraction.
And 1 cord. Okay.
Here,
Alrighty.
we can see.
Now, you're gonna have to reach in here, get your light cord.
A
Also,
gallbladder
it's the flesh too big in there.
and
Go
then
ahead and
being
grab your light cord and your
retracted
camera.
often
Don't put them on top of each other. Carry them separately because that's very delicate.
dissection of some of these fatty adhesions
Okay, I
of the
will take
gallbladder.
this.
This gallbladder grasper
Thank you.
can be secured
Yeah, and you take the
using a towel clip on the outside of the patient
scope.
or by being applied to the
Put it
assistant.
here.
Next, we'll talk about an important part of the operation.
Right, this is
which
one of the nails
dissection
there.
of Callow's triangle.
If that's where you'd like it.
Okay, never mind.
No,
Whatever you
if
like
that's
it.
where you want it, because you do have to go up there with all of this.
Anteriorly and superiorly.
I would go ahead and put the cord up here,
Subsequently, there is
but
blood
I would put the
dissection
scope on
of
my
the
back
area
table
of
because
interest
you don't wanna
around
drop
the
that and break it.
cystic duct and cystic artery where the peritoneum is overlying this. Note that diaphragm
Okay,
is
so
used
on
in this
the
area
normal
as it is very
saline-
close to important structures such as the common bile
Normal
duct,
saline,
which is
we're not
susceptible
going to inject it.
thermal injury. As you can see, the peritoneum is peeling.
Okay, so we
nicely
don't need
away.
that. This
And
isn't,
often these
does it get
instruments are used
injected?
to make
Okay, so I see a
wound
bubble
closure
in there.
posterior plane.
so you gotta make certain there are no bubbles, okay?
As you can see, opening up
That's good.
the instrument.
Alright, so with this, we're gonna inject it. With this, we're gonna put it inside.
Here we can see
That little
window
bubble.
being made more posteriorly. Another common method aiding the dissection
Put it
is
inside
using the section
there on
irrigation
top of
device.
Verus needle
This
to
allows
test.
for a nice gentle
Okay.
dissection.
So,
as you
alright,
can see
good
here.
morning.
Just gently peeling away some of the overlying tissue, peritoneum and fat.
They originally had
This
these
allows
lights
you
on
to obviously simultaneously use the
during
section
the
on the
very
bleeding.
beginning, but once they
But
get
also
in with the
irrigation
scope,
required.
the circulator turns these out.
Here we can see a good
Because we
example
want
of
it
blood
dark,
instruments
somewhat dark, they
being
call it a
used
green
to
light,
safely
like
open
a
up
soft
window
green light in there, so that you can
behind
then
the cystic
see, your
duct.
monitor.
Sometimes in medical students,
Okay.
when faced with a view such as
Send
this,
that
it
to
can be
me.
really difficult to
We're gonna-
decide what's what in terms of
So then the
anatomy.
circulator's gonna come over here and turn this on.
Diagram, we can see superiorly.
So
Yeah, I
somebody's
did,
turn
but
this on,
We
circulator,
can see the cystic
you
artery
turn on the,
and the cystic duct. The cystic duct coming down to join the common bile
and
duct.
this,
And
the
finally,
monitor.
the duodenum. Here we can see where the two
Okay,
plug
now you
ins
come up to
on
me.
the cystic duct
Okay.
and cystic artery. I think it's important to note how close these two structures are to other important structures such as the common bile duct
Could you
and the duodenum.
You wanted the 7 under?
Next we'll see identification
What have I got?
and ligation
7
of the
and
cystic
7.5.
duct.
7.5 first.
Here you can see where the cystic artery is being clipped.
Low budget.
And subsequently, a cap will be made. This goes to the second meaning that the subcystic artery left behind has the 2 clips applied. There's the third clip being placed nice and close to the gallbladder. And subsequently being
So the one for the,
scissors.
that's why I think it's hot.
It gets really hot.
The cystic duct is clipped much the same way as the
And it's
cystic
like
artery.
blinding.
Here you can see the first clip being applied to the cystic duct.
Sweet.
Next we see resection and removal of the gallbladder. Now that the cystic duct and cystic artery have been ligated and transected, dissection of the gallbladder can begin. And here you can see a hooked diaphragm being used and the appearance of the loose areolar tissue, which is the anatomical plane for dissection. And the hooked diaphragm is very frequently used in this part of the operation as you're working your way away from the important structures, and also you can often encounter quite a lot of bleeding in the gallbladder bed as it's
Let me
very
get another
close to the
7.5.
parenchyma. Here we can see how the hooked diaphragm is being used in the dissection gallbladder bed.
Okay.
Using the heel of the diaphragm and adequate retraction laterally of the gallbladder, and then easing its way off. Here you can see the gallbladder has been fully dissected off the liver, and you can see a bird bag just on top of the liver, and the gallbladder being delivered into the bird bag, where it can safely stay on top of the liver while the final inspection for bleeding in the gallbladder bed takes place. Here we can see suction irrigation
Oh, I
being
just
used
realized
to
this is the
make a
wrong
final
dummy for
inspection of
this.
the gallbladder bed, just to check for any bleeding from that liver parenchyma.
Okay, we're gonna do our
Yes,
best,
you can
but,
see
when we do the next laparoscopic one, we're gonna have to use the other dummy that has all the soft abdomen.
Finally, we'll talk about closure. Now, in terms of closure, the 10mm port size should be closed.
It's probably this one.
Superficial layer.
It's
This
that one over
reflects
there,
the future formation.
the guy with the
of
mustache.
hernia. The 5mm ports are often closed with subcuticular sutures or wound
Okay,
glue.
so you're gonna find the head, and you gotta put it in
Finally,
the
we'll
head
talk
of
about
the
the
direction. There you
complications of
go. You gotta
laparoscopic
show me
cholecystectomy.
the head.
Bleeding
So
may
I
occur
know.
from the cystic artery
then-
stump itself or the liver parenchyma in the liver bed. Infection, this might be surgical site infection or intra-abdominal infection. A bile leak might occur from the cystic duct stump or directly from the gallbladder bed itself. There may be inadvertent damage to the common bile duct, and this may require extensive
Then they
surgical
literally just throw
reconstruction.
that off the table.
Damage to other structures, this may occur during the operation or during the laparoscopic port in
Do I
surgery.
need to bring my basin?
It's important to mention the risk of the anaesthetic and VTE, or venous thromboembolism, to those patients with increased significant comorbidities. And finally, the risk of conversion to an open procedure or indeed failure of the procedure. So just to go over what we talked about today, we discussed the indications for a lap chole. We went over the basic anatomy
Okay, so what
important
you're
in the
gonna do is
procedure.
laparoscope.
The surgical steps were covered in a chronological order, and finally we talked about the complications. Thank you for listening to a video podcast by School of Surgery. Remember, you can follow us by searching School of Surgery on Facebook. You can subscribe via iTunes. Go directly to the website schoolofsurgery.podomatic.com, and we'd like to say a final thank you to Stores who made the video footage available.
So then you're going to
Thank you very much.
know that I'm gonna need it over here.
Welcome to
So
our
you're gonna
podcast from
take
School of
this,
Surgery. Today we'll talk about
you're gonna take what you
laparoscopic
need,
cholecystectomy.
and then you're gonna pass
We'll
this
cover the indications of surgery,
underneath here,
the basic anatomy
without it
relevant
falling
for this
off.
operation.
Pass the whole
We'll
thing
talk about the
underneath
surgical
without it
steps
falling off.
in a
And
chronological
give it to
order
your
with some
circulator.
video overlay, and finally discuss the complications relevant to this procedure. So in patients who require a
This is good.
cholecystectomy, the laparoscopic approach is the
I'm gonna
accepted
take your light cord,
unless the patient is
same
suitable
thing.
for laparoscopic
We're
surgery.
gonna find which
The
side
most common indication
hooks
is
here.
symptomatic gallstones. This includes biliary colic, cholecystitis, and also gallstone pancreatitis. Rare indications may include cancer, trauma such as gallbladder rupture, and a porcelain gallbladder. Contraindications of the laparoscopic approach may be identified preoperatively, as in the case of patients who have previous surgery, but also intraoperative complications such as uncontrollable bleeding.
And you're gonna
unsafe
perform what's called a white balance first. You're gonna take this and you're gonna squirt some on here, so you
Next,
go
we'll
through the
talk about the
motions.
important anatomy relevant for this procedure.
Okay,
Here, we
Okay,
can
so
see
you're gonna take
right
this.
and left hepatic ducts,
And
which
you're
are
going
drained
to
by
form
from
white
the liver
balance.
and converge to form the common hepatic duct.
and we look at the screen,
Gallbladder and travels
and
by
it's
the
supposed
cystic
to
duct,
beep,
which joins the common hepatic
and it
duct
will
to
say
form the common bile duct.
white balance, but
This
I
goes
don't
on
think
then
this
to drain
does.
bile
Okay,
via
so we're
the
gonna pretend it says white balance, so we're gonna put that down. This is now ready.
The next important
And,
part of anatomy
so when you are testing it, you say light on, I need to
the right
test for white
hepatic
balance.
artery
And then when
which
you're
is
done
a branch of the
testing and it looks
celiac
fine, you
artery,
say light off,
gives the cystic
because this
artery,
gets very
which
hot and it
directly
can cause
supplies the gallbladder.
operating room fire. Okay,
An
so we're gonna do our
important
timeout.
landmark is something called
Did my
Callan's
timeout.
triangle.
We've introduced
And this is
ourselves, what do you
surgeons
say?
Identifying Callan's triangle during
I am.
laparoscopic
Oh, I
cholecystectomy.
I'm Andrew, I'm your ST student.
The inferior border of the triangle is made up of the
I have
cystic duct. The
One
superior
liter.
border
1 liter
is
of
formed by the
normal
inferior
thing.
border of the liver,
0.9.
and the medial
0.9%,
border by the common hepatic duct.
and then I have
And together, These form a triangle.
30 cc's or 60, I don't know what you have. You probably
I
have
think
30
it's 6.
foot.
Oh, is it 30?
Looks like 30 from here.
The structure running through the triangle is likely to be the cystic artery, which is to be
Plane?
ligated
Okay.
for safe removal of the
Alright.
gallbladder.
Okay, I'm gonna take my local.
Now we'll talk about the operative steps,
I have
starting from the
marking,
beginning,
your
patient
appointment
positioning,
by plane.
right up to closure at the end of the procedure. So starting with step
Yeah, I'm
number
going
one,
where the belly
first we'll
button
talk
is,
about port
the
insertion.
umbilicus,
In a lap coli there are
okay?
usually four
And I'm
ports.
putting,
The camera
local
is
in,
inserted through the
needle
first
back.
port, the umbilical port, which is usually 10
why don't you
millimeters.
grab
We
me,
then have a
since
10
this is
millimeter
not a very
gastric
big
port,
patient, I'm gonna
a 5
need,
millimeter port
a
directly on the
Kelly.
gallbladder, and finally a 5 millimeter
Straight or
port
curved?
on the clavicular
curved.
Patient positioning is really important in this operation. It helps improve exposure of the right upper quadrant. To aid this, we often
Okay.
see patients
So I'm
with the head
grabbing
raised up.
the skin around the umbilicus and I'm pulling up, because I then am
This
going to
first
place
segment of
this
video
in.
footage
Sometimes
shows
they'll
the
make a little
port
stab
incision.
incision, sometimes they won't. Okay,
Okay,
so before I take this, you have to take the tip of that off. Okay, I'm gonna make a little stab incision, pulling up on the skin, stab incision, knife back, I'm still gonna use that. So this is the first time you don't take it away. And that's good, that's the right size needle. We don't do a skin, a size 10. Okay, this gets poked in to the umbilicus, putting that back.
You'll often be encountered by this initial
Okay.
view of the right upper quadrant. Here
Okay,
you
I'm
can see the
going
gallbladder
to
sitting in the
then
gallbladder
test
bed.
it.
We have
Is
some
that,
felt
12?
adhered to the gallbladder
blade?
surface, and you can see the liver behind.
Okay, it's in the right spot. If
Next
it
we'll
wasn't,
talk
they'd take
about
it out and do it
gallbladder
over
retraction.
again. Okay, insufflation. Oh, you haven't thrown your insufflation off.
We
Where's your
can see
insufflation?
The
Right here.
gallbladder
Okay, grab that.
compressed by a gallbladder grasper, and then being
This one?
retracted superiorly, often
You have faith in
retracting
me?
the liver with it.
So this end right here, this is the end that gets thrown off. Insufflation is at the same machine, so you're gonna pass this under, you're gonna hand this to me, and you're gonna pass the rest of that underneath.
Or by back into the assistant. Next we talk about an important
Just
part of
kinda
the
toss it.
operation, which is dissection of Callow's triangle.
Okay.
Here we
Now,
can
while
see
we're doing
the
this,
gallbladder
you've got to
being
hook up your
retracted
suction irrigation.
superiorly.
Suction irrigation is over here, so go ahead and grab your suction irrigation.
The area
Miss
of
Sue,
interest
for what blade is that? Is that a 12?
cystic ductus.
That's a,
15?
it should be either 15 or 11, usually
15 or 11?
15 or 11 is
Note
for
that
stab.
diathermy is used
Are we
in
insufflating yet?
We're insufflating, and so
11
I am
11
standing
is
here
more a
talking
point.
while it's
Mhm.
insufflating.
That's 15.
15? I know 15 and 12
As
kind
you
of
can
look alike.
see, peritoneum is peeling nicely away.
And they do this.
Instruments can be used to
They
measure
listen for the hollow sound
posterior plane.
of the abdomen, and you will see the abdomen coming up.
As you can see, opening up the instruments.
And then I'm looking at the dial, I'm looking for a particular number.
Here we can
Okay,
see
so first, the next thing I'm gonna wanna do, okay, here, while that's
more
happening,
posteriorly.
okay, you're gonna wanna grab your suction off of your instruments, your laparoscopic, remember the little suction instrument?
This allows
Those
a
things,
nice gentle
Okay,
dissection.
does it look like I have little
Is this
holes in the end?
Mhm.
Okay, grab that.
Some of the overlying
That
tissue
goes on
of the
here.
peritoneum and fat. This allows
Okay.
you to
Now,
also
this is going to
simultaneously
get-
use the section on the bleeding
Is it on?
and also
you
irrigate as required.
Okay, so you're going to, see, we've got all these wonderful pockets here, this is amazing.
Being used to safely open up a
See,
window.
that's where this becomes useful.
That's why I got the new one.
This has to be thrown off
Can be
where
really
suction
difficult to
and
decide
the
what's
irrigation is gonna be, it's in a bag up here. So we're gonna take what we need, which is not much, okay, hide it over there, and you can shut it with these little things, and you're going to toss that off with a
The
circulator.
cystic duct coming down to
Okay, so
blood.
we're gonna hang on to this much, and we can secure that with these.
Here we can see where we'd like to ligate the cystic duct.
Now we're
and
ready,
cystic
but
artery.
before
I think
we
it's
use this,
important to
you
note
have
how
to
close
prime
these
it,
two structures
which
are
means
to other
you are going
important
to
structures,
hit the
such
blue
as the
for
common
water,
duct
and you
and
will
the
see it
duodenum.
coming down the tube. You're doing this,
Next, we'll see identification and
you're
ligation.
hitting
of
it,
cystic
because you
duct
don't want it
and
to go all over everything, but you're watching it come down,
Here you
just
can
until
see
it gets here,
evidence
and then you
been
stop.
identified. The
Okay?
cystic artery
Check
is
the
being
suction, it
closed.
works,
3
we're gonna go
clips will
ahead
be
and leave
applied.
that alone now, okay,
And
then we're
six
gonna do
clip.
this. Okay, so the abdomen is
This
at
is
its
the second clip.
fullest, so
Meaning
what do you
that
think I need
the
next?
stump of cystic artery left behind.
Yeah, I'm
That's
gonna
two
put that in
clips
first,
applied.
okay, I'm gonna pull this
Then
out,
the third clip
And I'm gonna take this off. While I pull this out, you're taking that off. I'm throwing this back up here. And we have got, I have to attach that here, otherwise the abdomen is gonna continue to deflate, okay? That's why this needs to be shut. Before you pass this off, it has to be shut. So now the insufflation is in there and the stomach will still remain distended like that. Okay, now, what am I gonna need now? Because I gotta take a look before I place my other trocar. Correct.
Now you pass it to the back.
And you pass it like so.
Now that the cystic duct and cystic artery have been ligated and transected, dissection of the
Has this been white balanced?
and here you can see
Yes, sir.
hooked diathermy being
Okay.
used. And the
Okay, can I have the OR lights out, please?
which is the
These
anatomical
lights?
plane for dissection. And the hooked diathermy
And these
is
lights?
frequently used in this part of the operation as you work in your way
There we
away
go. Just the
from
one is
the
fine.
important structures.
Okay.
And also you can often encounter
Christmas.
I know, it's like Christmas.
There it is. There's a little fiber optic. Now, you see?
Here we can see how the
I'm looking in there.
is being
Okay.
used in the dissection of the gallbladder away from
Okay,
the
now
gallbladder.
is the time to bring up your instruments that you're going to use, okay? So I've already, I'm done with this. I only need it once, so put that back over there with your sharps.
Here you can see the
Okay.
gallbladder is
Now,
being
your instruments that you're gonna need up here are your two
and
D&G
you can see the
graspers.
wound bag
You wanna
just
show
above
him where
the
those graspers are?
gallbladder being delivered into the wound bag, where it can safely stay
They look
on
like
top of
forceps.
the rest while the line inspection.
No, that's
moving the
scissors.
gallbladder bed takes
Okay, we need
place.
scissors.
So here.
Yes, just grab them all and
I think all of them. Just grab all of them and go
There you
take
go.
care.
Okay.
Final inspection of the gallbladder
Those
bed.
go up here, but they face you because that's how you're gonna pick them up, is by the other end. Okay, we're kinda done with that, and we're done with this.
Are those all the ones that he would need? I just wanna make sure.
Okay, this
And then there's
is,
a dolphin, does he need a dolphin?
yeah, the
In
Maryland.
terms of
Okay,
closure,
here.
the 10mm port sites should be closed with a deep
Okay, this is a grasper.
This would prevent
That's a
any future
grasper.
formation of an incisional hernia.
These are the
The
scissors.
5mm ports are often closed with subcuticular sutures or wound glue.
This is the Maryland.
Finally, we'll talk about
Okay, there should be
complications
two
of
graspers.
cystectomy.
This one is just too big or?
Bleeding may occur from the cystic
If it's too
arteries
traumatic, there
itself.
should be another one. These are called atraumatic D&G or Davidson
There's only
Jet.
this one.
There's one
It's
with like a
halfway.
little spongy thing on it. That's an atraumatic.
This one?
Yeah, it looks like it has like a sponge on it.
Or directly from the gallbladder bed itself. There may be
Oh,
inadvertent damage
no.
to the
I'll take the other one.
and this may require extensive
Which one?
surgical reconstruction.
I can't see it.
Damage to
It's
other
only
structures,
halfway, that
this
one.
may occur
And this
during
one
the
is all the way.
operation or
Okay.
during the
I'll take this one.
laparoscopic incision. It's important to mention this
Okay, your two graspers are up here.
and VTE or venous thromboembolism.
Okay, and you might want to have your stapler on hand.
And
So
finally,
bring that
there is
stapler
the
up.
conversion to an open procedure
Okay.
or indeed failure of
There you
the
go, but
procedure.
you don't wanna,
So
okay,
just
so we're gonna
to
grasp it
talk
and
about
grasp
today,
it. Then we're gonna dissect.
indications for acoli, who render the
With
basic
this one.
important in the procedure.
Then we're going to
The surgical steps
staple,
occurred
then we're going to cut.
and
Okay, so we're
finally,
gonna push those over here. So once these are done, you can then lay those.
Okay.
So I'm looking, okay. Now, I'm gonna ask you to hold this and just hold it, don't move it. Okay, so I'm gonna take my knife, I'm gonna make my next incision,
Who made the video footage available.
okay?
Thank you very
Maybe I'll
much.
make my next two incisions. Well, they're gonna have to be over here, cause this is the only opening I have.
Today we will
Okay,
talk about
knife back, I'll
code
take that. You immediately
We'll
take care
cover
of
the
that.
indications of surgery,
Now,
the basic
I am going to go
development of this operation.
down in order
We'll
to
talk
see
about the
up,
surgical steps
okay?
in a
So I'm gonna show
chronological
myself over
video
here,
overlay.
and I'm gonna ask
And
you
finally
to
discuss the
hold this.
complications relevant to this
Okay.
procedure.
And that, there's one doctor that will let you do that a lot, and his name is Dr. Ninwin, he's the one that screams a lot. And he will say, hold it, you just say,
The most
hold
common
it,
indication
hold
is
it,
systematic
and very abruptly, because it's just a cultural thing for him to do.
and also causes
Okay, so then it does mean that he wants you to
rare
hold it.
indications may
Okay.
include cancer,
So I am going to
such
take
as
my
gallbladder rupture,
next one,
and porcelain gallbladder.
I'm going to,
Contraindications to the laparoscopic
I did my stab
may be
incision, I'm
identified
inserting this,
preoperatively
I'm
as
closing
indications
this,
that previous surgery
okay, so you're showing me up here.
such as uncontrolled
Okay,
bleeding,
so that I can see that when I insert this, I'm not puncturing an organ, okay?
Next, we talk about the
Okay, this
important
is supposed to stick. Okay, Now you're gonna take that I just put up there and you're gonna pop it in the next one, lock it, and make sure it's closed. Okay? Okay, I'll look over here now. Okay, hold this. Okay, I've already made my incision. Okay, you get the next one ready.
This is the next one, but it already has, take this out.
Oh, that had one in it, huh? Yeah, let's see if that fits. Oh, it's not gonna lock.
No.
I don't think we can get a, so we're gonna ask somebody to open another 5 sleeve. And we're gonna put those in your big bowl. Okay, take this one.
No, it was a whole troll card. We don't have another one that's just a sleeve.
Okay, just take that out. Okay, what happened to the other trocar? Oh, you tossed it. Okay, we're gonna pretend that you are putting this together. Okay, put that together and close it. Is it closed? Okay. Then I am, and so I'll say, show me over here. So you're gonna go down and show me over here. Okay, I'm popping that in.
What are those things? It's like hair almost.
Okay, I'll take a grasper. And how are you gonna hand that to me? Okay, now, if I am having a hard time getting this in here, you're gonna help guide it, okay? Okay, so I am, you really can't see anything in here, but you will notice that they can. Okay, so I'm grabbing tissue and getting it out of the way. Okay, and I'm going to lock it, and I'm going to say, hold this, and don't move it, is what I would say to you. And then I'm going to grab another grasper. Where's my grasper? I can't find it. Find my grasper, please. Okay, thank you. Okay, so I have now identified. Okay, hold the camera, please. I've now identified the cystic artery. I don't have another port that's big enough, but I'm going to be dissecting it away. Dissecting it away. Dissect. It's a lot of little tearing. Okay, I'm putting it back. Then I'm going to grab the camera from you. Okay, sometimes they will ask you to hold both of these, and you can do that because they're locked. You can do that like so. Okay, so go ahead and hold both of those. Okay, just don't move them. Okay, now I'm going to ask for the clips, or the staple is what it would be called. And I'm going to put this in a larger port, of course, not this port, it's too small. I'm going in and I'm going to put a clip on the one side of the cystic artery and then 2 clips on the other side. So it's going to be a total of 3. Okay? So that was the cystic artery, then the cystic duct. 1 on the one side that's going to be taken out and 2 on the other side of the artery or the duct that is going to be left in. Okay, I'm giving that back to you, so you grab it by the end. Because we don't want these up in the air like this. We want everything to go like this, low, okay? Okay, then you're gonna put that over there, okay? Scissors. Where's your help me there? This works a lot better on the other mannequin because these actually stay in place. Then I'm going to cut between the staples on one side, cut between the staples on the other side. Okay, I'm going to come out. You want to hold that trocar so it doesn't come out. And handing this back to you. Okay. Let go of this one. Okay. this one, I'm gonna unlock it. Come on, you'll hold that one. Coming out, okay, I'm gonna need the endo catch. Okay. So it's your job to pull that out and make sure that it's ready to go. This would of course go into a larger one like this one, like the big one. Okay, maybe a 15. Okay, so that would go in. I would place that in. And then we would watch it up on the monitor and you would see it. I would push down, I don't want to open it, but I would push down on this and the little bag would come out and then, I let go of one too many graspers. So this is grasping onto the gallbladder. This is why it's not at the hospital anymore. I'm telling you, they give stuff away that it doesn't work. Okay, so I have grasped a hold of the gallbladder, and I have it, so I'm gonna tell you, hang on to this. I've got the bag in there, and they will let you put that gallbladder in the bag. So the bag is in there, it's open, and then you're gonna have to look at the monitor, and you're gonna have to start moving it towards the bag.
Do they
No.
let you do it?
Yes.
Really?
Yeah. So they'll say, no, go up a little. No, I said up. No, go down. And then boom, we've got it. And then I pull back on this. I've got it. And then I'll say, come out with this. I will help you come out with it. And then you're going to grab a peon. Okay, because this is an extra large gallbladder. And I've got to open the hole up a little bit more. Stretch it open like this, and pull on it in order to get the bag out. Now, when I get this bag out, you're gonna be bringing up your little blue bowl.
The blue bowl?
The blue bowl, yeah. Okay, there it is. So we're gonna pop it in there, I've wrapped it around there, you're gonna take it to the back. You're gonna cut the bag open with your scissors, just pretend. Okay, and dump, you're gonna lift the little bag and dump the gallbladder and all its contents out in there, okay?
Does the tech go through it, or does the circulator?
Hmm?
Who goes through the gallbladder?
The doctor does.
Oh, really?
Yeah. Okay, so that's done. Okay, I'm coming out with one of these. Okay, let's get my suction irrigation going here. Okay, so this goes in one of these. Oh, wouldn't you know, it doesn't fit. There we go. Let's pretend it fits. Oh, it does. Okay, then I'm putting water in there, then I'm suctioning it. Then I'm putting water in there and I'm suctioning it. Water suctioning, and then I'm taking a quick but thorough look all around in there to make sure there is no bleeding or leakage. Everything looks good. Okay, I'll take that off this. You just pop that right up there. Okay, looks like. Alrighty. Insufflation off, light off. Okay.
It was a success. I said it was a success.
Was a success. Okay. Now, okay, lights on, please. Now, one of the main things that you've got to be concerned with right now is you have got to get rid of this because you want her to unplug all that because you've got to bring it back over to the end of your back table. Yeah. And then take this off. Yep. Secure that scope. Secure the scope over there. Okay. Okay, she's done that. So she would not put this up on the table. She would just leave it on the floor.
Oh, really?
Uh-huh. So then you can safely take these things
Just kidding.
and only touch up here what was up here. Okay, and you can drag the rest on the floor because it was on the floor anyway. Okay.
And then place it where?
And over there, just put it in your basin right there, just off of your table because we're not really done. There you go, just so that it's nice and safe and nobody steps on it. Okay, that's the light cord that you just stepped on. Here, bring it on over so nobody steps on it. And just, yeah. Okay, then you're gonna wanna get rid of these. take all your trocars, put them in your basin. Okay, you've got your normal saline here that you don't really need anymore. Okay, you've got your countable instruments. These are disposable, but these are reprocessed, so you're gonna take all of these back over, okay? And you're gonna place them down there. These are recyclable, so you can just stick them over at the end of the table. Okay, now I'm gonna need, oh, and this is recycled, this is recountable. This is not, this will get tossed. Okay, so now we've got these 4 holes. Okay, so I need a sloppy wet and a dry. Okay. Okay, so now's the time to ask for your dressing.
May I get my dressings, please?
Okay, then I'm gonna take my top ones off.
Do I take it off?
Are these the only thing that you guys have?
Ranch
That's the
and
only thing that's
bushes.
here.
Do you have honey mustard?
So remember, however many ports he makes, however many holes he makes, is how
Want me to
many,
really open them?
how many bandages you need over here.
There's only one bandage.
That's okay, we're just gonna pretend, but normally it would be like, we have 4 holes, it would be, steri strips enough, and then 4 bandages. And you would get some clean scissors, Okay, so you are going to do a final count. Pickups, thank you. You're gonna say, I need a final
I
count.
need a final count.
Mine says strength.
Okay, what, everything?
Here, I'll take those. Yes, starting with laps.
Okay, laps.
You can do this quickly.
1, 2 on the field. 3, 4, 5.
Weight hits.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Sutures.
No sutures.
Hypo or blades.
2,
How about blades?
1,
Bobby tip.
1.
Fred.
No Fred.
Scratch pad.
No scratch pad.
Crystal loops or peanuts.
No.
Okay. Your instruments that are down there.
I have 1 knife handle, 1 medicine on the field, 3. I have 1 acid brown. Acid with teeth, 2 acid with teeth, 3 needle holders. I have 2, 4, 5 Kelly curve, 2, 4, 6 Kelly straight, Edna, 2 peons, and that's about it.
Did you count your laparoscopic instruments?
No, the laparoscopic instruments.
1, 2, 3, 4, 5, 6, 7, 8, 9,
And did he show you the
10,
physical
11,
Bobby
12,
tip?
13, 14,
No.
15.
Okay. And then forceps.
Yeah, I did.
You did?
Yeah.
Okay.
Okay,
And count complete.
blue towel. So this is all right across here. Okay. Now what I'm gonna do, and the circulator would have already unspiked this. This is called spiking, when you spike it in the bag. Okay? And this is taken off. And here, this is taken off so that we don't continue to contaminate, so it's like rolled off, just like your gown is rolled off. There we go. And into the trash. Then we're taking towels. Okay, now you have to finish with your, okay, you can let go of that, you can get your wet and dry and finish wiping off all that betadine.
There's supposed to be like the list for each instrument tray, but I think someone just put it.
Okay, very good. Thank you, Andrew. And then they'll shake your hand. They will. They'll shake your hand, not like that. They'll shake your hand, okay? Oh, they go, hey, awesome, okay? And then peace out, and then you just continue.
Peace out.
So, and you can take this back, okay? Because then the circulator is responsible for coming on over and putting the
And we can.
I've had my hand shaken many times, and it's so cool. The first time, it's like, oh, my hand. You want to shake my hand? I'm the one.
And
We can clean.
that's a wrap.
It's very unfamiliar, isn't it?
Yeah.